Hi, everybody. My name's Garrett Fink, and today I'm going to be talking to you a little bit about aortic stenosis. Following your valvular disease lecture, we wanted to do a little bit of a clinical correlation. Talking specifically about aortic stenosis, it's not always as black and white as we paint it to be, similarly to a lot of things in medicine. And my goal for you today is to be able to see some of that in our topic that we discuss. I have three learning objectives for you today. I want you to be able to explain the physiology behind the signs on the physical exam that we see with aortic stenosis. I also want you to be able to explain three different common symptoms that can be associated with aortic stenosis. Finally, I want you to be able to describe the best test for a patient that has a confirmed murmur with symptoms, and also why we utilize it in our clinical decision making. All right, let's briefly review the physiology that you already know. So, we know that the aorta arises from the left ventricle, and the aortic valve is what separates blood from going out of the ventricle too early and prevents it regurgitating back into the left ventricle. Here's our aortic valve, and as we see, as calcifications come on it, it makes it harder for blood flow to get through. This results in our normal pressure of 120 increasing, and that goes with the severity of the disease. We know that as the aortic valve stiffens, the left ventricle is going to have to work harder to get blood flow through. As this changes, we notice that the murmur that we typically hear with mild aortic stenosis tends to delay a little bit. Going back to our murmur diagram, we know that this is S1 and this is S2. And our typical pattern looks a little bit something like this. In a mild aortic stenosis, the peaks are really early on because blood flow is able to pretty easily compensate for the increase in stiffness of the aortic valve. But as the disease continues to worsen, we see that this valve actually, we notice that the murmur starts to delay in where it peaks. So, right here in a mild case, we see that the peak is pretty early on in systole. But as we progress and the murmur becomes more severe, we see it delay a little bit more. Going back to the valve disorders lecture, this is still the typical crescendo decrescendo murmur that we're well aware of. But we start to see that the murmur looks a little bit different than what's typically presented on shelf exams and the USMLE Step 1. Another thing that we commonly see is that we also start to hear an S4 kick, like we do with a heart failure with preserved ejection fraction, as that ventricle starts to stiffen. And finally, because it takes so long for the blood to get out of the aortic valve, that's where we can start to see that pulsus parvus et tardus. Those are the three key things that I want you to take away for the physiology as this progresses. With number one being that there's a delay in the peak of the murmur. Number two, we can hear an S4 kick. And finally, we can get delayed pulses. And all of this makes sense, but how do we apply it to our patient population? So, typically in aortic stenosis, things can be a little bit complicated because typically patients have other conditions that are going on. But in isolation, aortic stenosis can present with some scary findings. Patients can develop one, chest pain, particularly with exertion, similarly to a coronary artery disease. Two, we can have patients pass out or they can syncopize. And finally, these patients can develop shortness of breath with exertion, similarly to a heart failure picture. And this right here is what led our patient to come in. Now, obviously, whenever a patient comes in with any type of chest pain, it's always smart to get a troponin and an EKG to rule out if they're having an acute myocardial infarction. Similarly, with syncope, it's never a bad idea to get a head CT without contrast to rule out stroke. But this patient of ours, we know that he has aortic stenosis because we heard the murmur. And the best test to test for that is going to be an echocardiogram. The echocardiogram is really important as it can guide our decision on whether that patient needs an aortic valve replacement or not. Typically, if they're having symptoms or the valve is severely dysfunctional, those can all be indications, but the specifics on that are kind of beyond the scope of what we're talking about today. So these were the basic ideas that I wanted you to take away from today's lecture. Often, as we've seen here today, patients are much more complicated than just the conditions that we associate with them, but my three takeaways are this. Patients can develop chest pain, dyspnea, and syncope all alone from aortic stenosis. Be careful to watch for these symptoms as they can be predictors of pretty severe disease. Some concerning physical exam findings can be a delay in the pulse, the S4 kick, and also a delay in the peak of the murmur. All of these are things that we can do at the bedside or in clinic to help our patients. Finally, if you have a murmur and the patient is having symptoms, you should always proceed with an echocardiogram to assess for disease severity. Like I said, the specifics are outside of the scope of today's class, but at some point you'll need to know them. I'm going to pause the video now, and we'll continue on with some practice questions. All right, time for our first practice question. So our first patient is a 64-year-old male who's coming to the ED found to have substernal chest pain with exertion. He's found to have a crescendo, decrescendo murmur late in systole. We also note that he has an S4 kick and some delayed pulses. We were smart and got troponins and an EKG, both of which came back normal. What's going to be our next best test to assess for this? Give you a second to think about that and come back with your answer. So our next best test is going to be to get an echocardiogram. You could argue that you could repeat his troponins and his EKG, but we know that he has aortic stenosis. And that late finding, as well as the S4 kick, indicate that there's some changes to his physiology that could be coinciding with severe aortic stenosis. So, our next best test is going to be to get an echo. If he was having lightheadedness or he actually passed out, it wouldn't be a bad idea to go ahead and get a head CT without contrast to rule out if there's anything neurological going on. But in this patient, we painted a picture of aortic stenosis with the systolic murmur. And remember that these valvular diseases can in themselves cause disease. Going to pause again and we'll come back for the next question. And now we're back with question 2. We're going to use the same patient as we did in the last practice question. Our patient had come into the ED with substernal chest pain. Which of the following is not indicative of severe aortic stenosis? I'm going to let you pause the video now and come back whenever you're ready for the answer. So the correct answer here is choice C, the 2 plus pinning edema. Pitting edema can be a sign of many different diseases. It's not very specific, but it can be indicators of pretty severe disease. We can see it in people with chronic venous insufficiency, and in more severe cases, we always have to think of the liver, the kidneys, as well as the heart. The delayed pulse and the delayed systolic murmur that we see with aortic stenosis come from blood not wanting to flow through the aortic valve. As it continues to stiffen, we need to generate more pressure in the left ventricle to get it through that valve, and that typically comes over time as the ventricle begins to squeeze. The S4 kick comes as a consequence of that. As the heart is having to work harder to generate higher pressures to get blood to flow through the aortic valve, we start to develop ventricular stiffening and ventricular hypertrophy in that chamber. And as a result of that, we sometimes hear the S4 kick there. I hope that you all learned something from this short chalk talk, and hopefully it helped to prove that not everything in medicine is as black and white. If you need any further instruction, please feel free to reach out to Dr. Paternastro or myself. I have also linked a YouTube video below that helps to demonstrate some common valvular disease and the murmurs that are associated with them. There's also some practice in the additional folders as well. Thank you all for listening, and I hope you all wish you all the best in all your endeavors.